Thank you. Thank you, dear chair of the session, dear colleagues, dear esteemed lecturers. And I want to follow up with your presentation because at the end we speak about the same theme. It is the therapeutic patient education, but only on different ways. So we start always our discussion with the patient based in incorrect assumptions. Patients want to change behavior, but we are advising optimal health is motivator for change, or patients are either motivated to change or not. But first, we need to change our thinking from patients are non-compliant to patients are unsuccessful at managing their own care. Patients are not yet engaged in their own care. So we need to consider that chronically ill patients make many daily health decisions, and sometimes they make unwise decisions. They don't fully understand the implication of particular health decision, and they lack support to make better choice. About 90% of patients lack skills to manage their health prevent disease. A patient calculation. In a year, we have about 8,766 hours. From them, a patient have only 6 hours per year in the doctor office with dietitian or any other health professional. So for the rest 8,660 hours, he is in his home and he has to take decision about healthy diet, physical activity, monitor blood glucose sugar, take medication, manage sick day, and manage stress, coping with it. So it's not very easy. How we can influence, not to engage the patients. Tell patients what to do, give advice. What Dr. Joao already said. Misjudged sense of importance regarding behavior change. Use scare tactics, argue, blame them for no willpower or self-concern. Overestimate readiness to change based on their saying that I am ready to change or I want to change. Take away control, generating resistance. What it is better to do in this case? Listen is the first thing that we need to do. Don't jump on first things patients say. Understand behavior change and motivation. Change clinical visits from to-do list to helping patients identify and establish care priorities, and help patients develop a care plan to improve outcomes. Can we be engaged in this educational process? 23% of our patients adopted new health behaviors but unsure could maintain if stressed. Remaining 77% of the patients participating in the study remain passive, about 12%, lack basic facts to follow treatment for recommendation, 29%, and have facts but no skills or confidence, about 36% of them. So there is still a lot of work to do on this direction. But I wanted to ask each of you, what is the most important thing for you? The first, increasing patient education. Raise the hand. Who agree with it? Spending more time with patients and developing a shared relationship between patient and provider. I think the third includes all these together. So, the ideal personal care-centered approach is related with patient engagement about self-management, shared decision-making, and coaching. Education and self-management, it's about information, technical skills, but also skills to act on problems. Problems due to poor disease control, but also to identify patients' problems in self-management. Disease-specific knowledge, but also to improve patients' confidence to change. And the goal is behavior compliance to improve outcomes, but it is more important to increase self-efficacy to improve outcomes. About 40 to 80% of medical information that are given to the patients are forgotten immediately. Half retained is incorrect. Physicians thought about 90% of patients understood medication side effects, but in reality, about only 57% of them understood it. So, there is the law of halves and need for choices. Only about half of those for whom an intervention is appropriate will accept it. Only about half of those will follow it. Only about half of those will benefit from it. So only 1 in 8 patients of the starting point. And 60 to 70% of patients with diabetes have not received self-management intervention, as Professor Milenkovic already said. Thus, diabetes self-management needs to include choices for participants among channels and emphasizes the interventions. Just an example of medication adherence. Take 3 tablets by mouth 2 times per day with food for 14 days, then take 2 tablets 2 times per day with food for 14 days, and so on. I'm pretty sure that almost anybody of us will remember it at the time that we are outside of the consultation room. So you can imagine for the patient, some of them they are old, some they have very low literacy, and it is very difficult to understand. So we need to be very careful. So what is the most important thing is the teach back method to confirm patients understand their medication treatment. Tell me why you need this medication. Tell me how you take this medication. Teach back is not a test for patient knowledge. It's a test of how well we explain something to our patients. Health literacy is a very important part of the education. It's the capacity to obtain, to process, understand basic health information and services needed to make appropriate health decisions. Only about 12% of adults have proficient health literacy. So lower literacy, it's translated in more admissions, more emergency room visit, higher cost, higher risk of poor health. For example, if we take the keep your glucose in normal range, what does it mean? In this case, you can see on the left side a picture of an oven. So if we want to cook something, we need to put it in the same temperature for a certain period of time. Only in this case, we will have a well-cooked meal. Otherwise, it will be either burst or not well cooked. So this is why we need to have a normal glucose control to have a better health. So what is important is to use the proper words with our patients. So in place of ailment, for example, to use sickness or illness. Adverse effect, we said bad effect. So to use simple words. Benign won't cause any harm. Condition, how you feel. Health, do you have any health problem? Oral, by mouth, vertigo, dizziness, and so on. What is coaching? This is a little bit different from managing when we make sure people do what they know and how to do it. Training, we teach people to do what they don't know how to do it. Mentoring, it's showing how those who are good at doing things do them. And coaching is helping people to identify skills and capabilities and empowering people to use them as best they can. So for this, it is important to have a motivational interviewing, which is a collaborative, patient-centered form of guiding to elicit and strengthen motivation for change. It is non-judgmental, non-confrontational, non-adversarial. It explores and resolves ambivalence. It helps patients envision a better future and become increasingly motivated to achieve it. For this reason, I wanted to show an example of our training program with people with diabetes, not at the hospital, but at the association. We are not as strong as APDP, Portuguese Association, but still we have a good number of people coming for consultation in our association, and we try to create a program which is a little bit special because people have together every time together. In total, we have 50 patients participating, but the group it is of 6 to 8 patients in each session. And they met every month, but they decided by themselves what will be the theme to discuss in the next month meeting. During a 6 month period, a monthly group session was held with diabetic patients. A diabetologist and a nurse were participating as facilitator and educators during the session. The glycated hemoglobin, lipid profile, and anthropometric measurements has been completed at the beginning in 3 and 6 month period, and also quality of life for people with diabetes. These are some of the pictures from the group sessions. They were face to face or in group session. The doctor here is Professor Budo, who is a retired endocrinologist. So we are using some resources for people that are still able and willing to be professionally active. So no lose of money for it, but also giving some satisfaction for these people. From 50 participants, 47 or 94% of them completed the 6 month educational program. About 21% of them were young people with diabetes below the age of 25, and 55% were males. Median age was about 52, and the diabetes duration about 7 years. The average glycated hemoglobin at the beginning was 8.4, and this you can see the result. So it was a small reduction, but significant for the weight, a good increase in satisfaction with treatment for people with diabetes, and a decrease of about 0.7% in 6 months of glycated hemoglobin in our study group. And for the lipid profile, we saw a decrease, a slight decrease for the total cholesterol, a better result for the triglycerides, and an increase in HDL, probably due also to the increased physical activity of this person during the project. Four principles of motivational interview. Express empathy, not pity. Put yourself in patients' shoes. Develop discrepancy ambivalence. Explore how they want their life to be and how it is now. Roll with resistance. Expect it. And support self-efficacy or empower. And for this, there are some helpful tools such as open-ended questions, affirmation, reflection, and summaries. We need to care and to transition our coaching model to improve transition of care, to encourage patient and caregivers to take a more active role in their own self-care, not doing for, but empowering patients to do for themselves. It is a tool that everybody can use. Patients engaged in coaching have better outcomes, effective to avoid downward trends or keep patients at new normal. Program consistently, reduce 30-day hospital readmission and cost, and 6-month day hospital readmissions. As conclusion, we can say that coaching model is a pragmatic intervention that primes the patients to self-manage by adhering to medication and make relevant behavior changes. It is important to encourage patients to take greater initiative in therapeutic alliances, which enable treatment to be appropriately intensified according to guidelines. It's better to create your own experience based on your resources, availability, and most of all, readiness of your staff to start with it and to go on with it. We need to remember that $1 spent for therapeutic patient education saves $3 to $4 of health system. But for this, it is important not only to have guidelines, but how to use them in practice. Otherwise, it is like to have a guidelines to build a bicycle, but you cannot be able just to have the guidelines. You need to have some experience with it. And I want to finish with a saying from Benjamin Franklin that said, "Tell me and I forget. teach me and I remember, but involve me and I learn. So, as everything in life, this is true also for therapeutic patient education. And I am very glad that we are here because everybody know about Banting and Best. Some of us know about McLeod, but it was Collip who made the purification of insulin and made it available without any risk for people with diabetes. And the diabetes education is something like Collip did. So it is a purification of knowledge and treatment to use it better for the better outcome for our patient. Thank you very much.